I'm Dr. Paul Singh from the Eye Centers of Racine and Kenosha out here in southeastern Wisconsin. I'm a glaucoma and anterior segment surgeon and a huge fan of the MIGS space. One technology I've been really excited about and been utilizing for the last few years now is the iTrack systems. It's a catheter that really rejuvenates the outflow system. It's a stent-free option that circumnavigates 360 degrees of the canal. Not only does it break the herniations that we see in the canal in many studies, but also viscodilates. So it's really flushing out the entire distal channel and also opening up the TM. So with this said, wonderful mechanism of action, question is, how long does it last? There's some thoughts that maybe it only lasts a few months, and some people think maybe it lasts for a few years. I have a really good friend of mine, one of my favorite people in the world is Dr. Mark Gallardo from El Paso, Texas, who's a glaucoma specialist and very well versed on the iTrack and many other MIGS procedures. And Mark, again, thank you so much for hanging out today. I really appreciate it. You've had such a wealth of experience and knowledge behind the iTrack and other MIGS procedures and MIGS devices. And I know you recently presented your 36-month data on efficacy and outcomes of the iTrack system. So I'd love to hear more about that data, but also your experience and your thoughts on the iTrack system.
You know, I remember going to my first symposium when the iTrack was being discussed, and of course it was one of those presentations that ICON was giving, and it really made me incredibly interested in canal-based surgery. And we actually have quite a bit of experience with canal-based surgery. If you go back to just looking at viscocanalostomy, we have 30-year data on these patients. And when we first started looking at viscocanalostomy, we were only able to treat about 6 clock hours total of the outflow system. And typically that outflow system was on the superior edge of the canal because we'd make our dissection or scleral dissection superiorly. And so when we viscodilated, we were only able to viscodilate 3 clock hours in each direction. But as you know, most of the distal collector system is inferiorly and inferior nasally. So when the iTrack catheter came out, we're able to fully treat the entire system. But of course, when canaloplasty was first developed, we implanted a tensioning suture because we found that the Schlemm canal in patients with open-angle glaucoma or primary open-angle glaucoma was essentially collapsed in on itself. And at the time, we thought we needed a tensioning suture to keep that outflow system open. So when we converted to performing viscodilation through an ab-internal approach without implanting a tensioning suture, that did lead to some questions on the longevity, on whether or not simply viscodilating would allow for a maintenance of pressure control. So being able to present our 36-month data has been very helpful because there was some speculation that the effect might wane over time. And what we found in a gist is that when we looked at our 1-year, 2-year, and 3-year data from this cohort of patients, is that the ability to viscodilate using the iTrack catheter has been able to maintain not only a pressure reduction, but medication burden reduction as well.
That's an important part of it, you know, and we always think of, I want more reduction of IOP, but, you know, the definition of success now, and I think the MIGS space is also reduction of medication burden, compliance issues that we face with a lot of these patients as well.
And of course, one of the benefits of having the iTrack catheter for so many years is that this is one of the MIGS procedures that we can do as a standard basis. And so when we looked at our cohort, half the patients were done in conjunction with cataract surgery, and the other half of the patients were done as a standalone procedure. And that's what's really important because most of these patients that had standalone surgery were being operated on because their pressures were uncontrolled. And in the past, when we had patients who were uncontrolled on max therapy that have already had SLTs, the next step would have been a filtration procedure. But I always try to do an angle-based surgery first in the vast majority of my patients, simply because living without a bleb is far much more comfortable for patients. Quality of life is better. The cosmesis of it, the risk of developing blebitis or bleb leaks are really simply scarring. And I remember when we first did when I was doing residency, we still had some faculty members that were doing scleral tunnel cataract surgeries. But if they had glaucoma, they would do clear corneal incisions because they wanted to preserve the conjunctiva in case the patient needed a trabecular in the future. Well, I view the angle as being our new conjunctiva because I want to manipulate it today, but I also want to preserve tissue because we all know in glaucoma that there's not a single procedure that lasts forever. And I want to be able to come back and treat the patient with an SLT 360 degrees. I want to be able to implant microstents in the future, or even try to rejuvenate the system again. I know I've had a lot of colleagues that I've spoken to that have viscodilated with the iTrack, and then several years later have come back and performed the procedure again and still got a result. So I want to preserve as much tissue as I can so I can come back and manipulate that tissue again. For too long, we really haven't emphasized the natural pathophysiology of the conventional outflow system. And if we go back and look at our basic science series book, when we talk about outflow and resistance to outflow, all we ever talk about is juxtacanalicular tissue. But there's disease throughout the entire continuum of the outflow system that's actually addressed when we viscodilate with the iTrack catheter. Laboratorily, though, when we look at the viscodilation, we're actually able to see microperforations in the inner wall of Schlemm's canal, which is important because we have a population of micropores that actually dissolve over time in patients with glaucoma. So aqueous is unable to transcend that continuous endothelial layer that's connected by desmosomes. It essentially is a blood aqueous barrier. So with that reduced population of micropores, aqueous is unable to get into the canal. But when we viscodilate, we mechanically force Helon or Helon GV or whatever we're using through that inner wall of Schlemm canal, creating microperforations. But we're also separating the trabecular lamella and even causing a change to the extracellular matrix of the juxtacanalicular space. So it treats the proximal system and the distal system. So there's a lot of disease in that system that we're rarely taught, but we're actually trying to manipulate now to preserve and restore the natural outflow system. So I like to try an angle-based procedure first. And because we can use the iTrack catheter as a standalone procedure, for me, it makes sense to try to rejuvenate that natural outflow system, similar to the fashion in which cardiologists try to utilize coronary arteries. They try to stent or do balloon angioplasty before they actually crack open the chest and perform the larger procedure. So I like to try to maximize the outflow system in a patient first, and if over time it stops working or if we're unsuccessful at reducing the pressure to target because their natural outflow system is just too diseased, I can at the very least tell the patient that we've tried everything we can to rejuvenate their natural outflow system. It just didn't work. Now we have to go to a larger procedure.
You know, and I love that because patients love to hear the word rejuvenation. It's kind of like a nice phrase for them to hear. And I love saying that to patients. And then when I say that, they really get excited. Oh, really, this is natural. It's kind of utilizing my natural outflow system, so to speak, which is wonderful. But with that said, though, you know, I think there's a perception that if it's so benign in terms of adverse events, we're not destroying tissue, we're viscodilating and rejuvenating the natural outflow system, that the efficacy is not quite there. You know, we have episcleral venous pressure. That's why we limit the hypotony issues with conventional outflow pathway. But there's a thought that, well, if it's really benign, it can't really reduce the pressure, especially long term. And your 36-month data, I thought, was really remarkable. You had a 32% reduction from based on 20 millimeters of mercury down to about 13.4. That's amazing. Tell us more about that. And really, was it just only in the cataract population, or was it even a standalone population?
So when we looked at the cohort as a whole, all eyes combined, it was just all similar. Really, it's about 20 to 13, whether it was with cataract surgery or just iTrack alone. And you know, I think for the longest time, we had this misconception that MIGS were minimally effective. But I think now it's almost common knowledge that MIGS are actually quite effective at delaying filtration procedures.
And so I think it's also important to understand, though, that it's not just IOP, though. In your data, which I thought was fantastic also, at 36 months, it was reduction of IOP and a reduction of medications. You mentioned earlier how important that is. Because I know for me, one of the fears that I think I have, and as well as a lot of the colleagues have, is if I'm going to take someone for a standalone MIGS procedure, part of the definition of success and part of what we internally are hoping to get is a reduction of medications. Because I have a number of patients who are quote unquote controlled IOP-wise, but they're on 3 or 4 meds, and my goal is to get them off of some of those meds. So tell us about the reduction of medication burden at 36 months and how important that was for you.
You know, reducing medication is quite important for many reasons. But we've got about a 50% reduction in medication burden, going from about 2.5 to about 1.5. And it's important for many reasons. And first and foremost, it's just the economics of using medications. There's the donut hole that we have to worry about where patients have to pay full price for their medications. Compliance, we know that after the first drop, compliance becomes an issue. In West Texas, there's a significant amount of dry eye, so every drop that I add increases to the ocular surface disease. One of the things that we don't discuss enough or emphasize enough is the fact that benzalkonium chloride, which is a preservative in every single generic glaucoma medication we have, and a lot of branded glaucoma medications we have, is pro-apoptotic. And so essentially what it does, it leads to death of the endothelial cells that line the trabecular columns. And as those endothelial cells disappear, adjacent trabecular columns fuse to one another, and it decreases the effective filtration rate. So it's paradoxical. We're giving medications to treat a system, but damaging it at the same time. So by reducing our medications, I think long-term, it's going to be beneficial to patients because we're reducing the toxic chemicals that we're actually having patients instill in their eyes on a daily basis.
There's always this thought that the reason why MIGS works is because you're doing it at the same time of cataract surgery. And the cataract node surgery, no doubt, has IOP reducing effects. And so the question I have for you, and if you could help us understand, what were the differences between the cataract combo with iTrack versus the iTrack alone?
We saw a significant reduction in both IOP and medication burden in both subgroups. Both enter our 1-year manuscript we published in Clinical Ophthalmology, and now the 3-year data that we presented. It's almost splitting hairs if we try to compare the two, because it's still in the pre-op 20 range on about 2.5 medicines, and both go down to about 13.5 on about 1 to 1.5 medications, whether it's standalone or in conjunction with cataract surgery. So it's still quite effective, just like when you look at canaloplasty data, that we have significant long-term data on canaloplasty, with and without cataract surgery. In fact, when we talked about canaloplasty initially, it was a standalone procedure in those patients. But we have been able to see a significant reduction in IOP as a standalone procedure. And I think that myth that our pressure reduction is solely from the cataract surgery is being dispelled at this point.
And looking at your 12-month data versus your 36-month data, it pretty much, when you look at both presentations, it is very similar. So the kind of the stability and maintenance of efficacy in IOP and safety, I think, is maintained over the 3 years. That to me, I think, is really important, because we can talk about 6-month and year data, but really most glaucoma studies that show the differentiation is really at 2 and 3 years, which is what you're showing, is stability.
Right. And you know, the one difference between the 1 year and 3 year is just our overall N. As you know, with anything that's retrospective, even with some prospective studies, you do lose some patients to attrition. Overall, when you look at the two cohorts, there really is a stability in both the pressure and medication burden reduction, not only in the combo phaco iTrack group, but in the iTrack treated patients as a standalone procedure. So that's one thing that I was really excited about, because it really did confirm just what I was thinking long-term in these patients.
Yeah, no, I think that's fascinating. And for me, what I loved so much about your 12-month and your 36-month data was that regardless of kind of your population of patient, whether it's advanced, mild, with a cataract, without a cataract, even we'll talk about ethnicity in a second, you're pretty much getting down to that 13, 14 range.
When I am going to perform a MIGS procedure, I really evaluate the angle. And when I look at the angle, it really directs me on which MIGS procedure that I want to perform. So when I look at an angle, I really pay attention to the pattern of pigmentation of the pigmented trabecular meshwork, whether or not it's homogeneous or very variegated in nature. I find if a patient has a very variegated pattern of pigmentation, it gives me a clue that their outflow system, although we know is segmental in nature, that their overall patency is probably very segmental as well. If I see a more homogeneous pigmentation to the TM, then it kind of tells me that overall the outflow system in general is patent throughout its entirety, and that its health is relatively equal. And in those patients, I've found that when I'm using the iTrack, they tend to function better over time, as opposed to those that have a highly variegated pattern. I'm sure you've encountered patients when you're performing canaloplasty that you can't circumnavigate 360 degrees because there's just stenotic areas, or even as you're passing the catheter, it's actually quite tight, and you actually have to almost force the catheter through. I found that to be more common in patients that have that variegated pattern. I just think that overall the proximal system is also highly diseased, and it's a little too diseased just for viscodilation. So I actually like to either bypass it with a microstent or deroof it in general by performing a goniotomy. So there might also be a little bit of selection bias in my patients because I'm not randomizing my patients. I'm actually looking at them and trying to find the right procedure for that specific patient.
And I wish we had more time, but I really appreciate you spending this time with me today and helping me understand better the iTrack and your data, which is remarkable. And we need more data like that. Are you planning on continuing this subset? And I know you had about 50 patients in the 36-month data. Are you going to follow those patients longer?
Of course, yeah, we're going to give it some time and collect the 5-year data.
Fantastic. Well, Mark, thank you so much again. Hope you hang in there and look forward to finally seeing you soon in person.